Hello, everyone, and welcome to today's webinar. My name is Leah Ashragi, and I am the Senior Director of Clinical Research at Dr. Susan Love Foundation for Breast Cancer Research. For those of you who are joining us for the first time, I'd like to take an opportunity to introduce you to our organization. Dr. Susan Love Foundation challenges the status quo to end breast cancer through innovative research and improve the quality of life. Improve the lives of people impacted through education and advocacy. We drive collaborative, cutting-edge research with non-traditional partners, shed light on the collateral damage of treatment, and actively seek ways to diminish it, and interpret science to empower breast cancer patients. Many of the projects the foundation undertakes are designed to increase our understanding of the human breast, where breast cancer starts and what enables malignancy to occur, with the ultimate goal of developing methods to prevent it in the first place. The foundation is also committed to participation in research that has the potential to positively impact the lives of all people who are at risk or who have breast cancer. Breast cancer happens in people, so research needs to be done on human beings, and that means women, men, non-binary people, everyone who gets breast cancer. Our Love Research Army, formerly known as the Army of Women, is committed to encouraging and facilitating breast cancer research in all people, regardless of age, race, gender, sexual identity, with or without a breast cancer diagnosis. We are committed to thoughtfully engaging over 380,000 members by providing them with ongoing real-time access to an array of studies. So today's webinar is part of the Love Research Army study series, where we invite the researchers who recruit participants from the Army to present their findings to our community. And we're really excited today. Joining us are researchers Dr. Tonia Poteat and Dr. Lorraine Dean, presenting the results from their study titled Our Breast Health, the Access Project. The purpose of this study was to learn about the best ways to improve access to breast cancer care and treatment for members of the Black LGBQ-SGL community. The initial call to action for this study was on January 17, 2018, and the researchers closed enrollment on October 29, 2019. The Love Research Army provided them with 6 women who were interested in enrolling in the study. Dr. Poteat and Dr. Dean will be available to answer your questions from our viewers at the end of the webinar, so please submit your questions using the Q&A box. While we will try and answer as many questions as possible, please note that we may not be able to address every question today. So I will now turn things over to the research team to get started with their presentation. Thank you so much.
Great, thank you for that kind introduction. And I learned more about the Love Research Army, so I appreciate that. Dr. Dean and I have divided the presentation in this way. I will start by reviewing the study and our results, and Dr. Dean will provide answers to the Q&A, and we might even have a little conversation with each other if there's time. So I want to start by making sure that we clarify that it wasn't just the 2 of us. It took an army, not just the Love Research Army, but an army of researchers to really get this done. And I want to make sure that we acknowledge all the people that were involved and integral in making this happen. So the goals for the webinar are threefold. One is to describe why we did the study. The next is to talk through our recruitment partners and our strategies. And I'll talk a little more about why that was important to us. And then to outline the qualitative and the quantitative findings. So to motivation, there is data that Black women experience disparities in breast cancer. They have a longer time between mammograms, they get diagnosed at a younger age, and at later stages of disease. There's also data that lesbian and bisexual women, and we'll use the term sexual minority women for this talk, are more likely to have risk factors for breast cancer, and some studies show that they have lower rates of screening. But what about women who are both Black and sexual minority? And to share a little of my personal experience, I'm a Black sexual minority woman, and I've lost many of my friends to breast cancer, and a lot of my friends have been deeply impacted by breast cancer. And I was saddened to see that there wasn't a lot of information available on the experiences of Black sexual minority women and breast cancer, and was very excited to partner on this study. So the first thing we did was to make sure that we found what was available in the literature and what was not. So Joanna Malone, as you can see here, led a systematic review of the literature going all the way back to 1990 to see what was available in the published medical literature on breast cancer screening and care among Black sexual minority women. And it's probably not a surprise to any of you that we didn't find very much, unfortunately. What was fortunate is that around the time that we were thinking about how we could move forward to try to fill that gap, there was a funding opportunity that became available through the Johns Hopkins Faculty Innovation Fund. And I will say at that time, both Dr. Dean and I were at Johns Hopkins. So we applied for funding and we were successful. And we planned what's called an exploratory sequential design for this study. We started with qualitative interviews that focused on Black women's experiences after an abnormal mammogram or breast cancer. Basically, we wanted to talk to Black sexual minority women about their experiences, both to understand in greater depth, but also to inform our development of the subsequent survey. And then the survey would include a broader range of women, and I'll talk more about that when we get to that section. And we wanted to interpret sort of what was the meaning and where were there factors where we could intervene around breast cancer screening and care for Black sexual minority women. We used a broad array of ways to recruit people. We had separate recruitment for the qualitative phase, and you can see on the left one of the flyers that we used to reach out to Black sexual minority women. And then we had separate recruitment material for the broader study that included a range of women with different sexual orientations and racial identities. Our main community partner for this study was ZAMI-NOBLA. And ZAMI-NOBLA stands for National Organization of Black Lesbians on Aging. The word ZAMI is a Carriacou word for women who work together, and it was also the title of Audre Lorde's biomythography. And she's a well-known Black lesbian feminist who died from breast cancer. ZAMI-NOBLA was engaged through all stages of the study. They participated in the study design, the data collection, and interpretation of our findings. The founder, executive director, Marianne Adams, is a community activist, a retired researcher herself, and a breast cancer survivor. So ZAMI-NOBLA, and particularly Marianne's involvement in the study, was crucial to making sure it was grounded in the lived experiences of Black sexual minority women. We collaborated with many other people for recruitment, and you can see the array of people listed here, including the Love Research Army, but also a community activist, Erica Hart, the National LGBT Cancer Network, the Sexual and Gender Minority Research Office at NIH, Living Beyond Breast Cancer, the Pride Study, and several others. So now I'll start talking through what we found in the study. So the first phase was the qualitative phase. In that qualitative phase, we enrolled women who were 35 years of age or older and identified as Black. They needed to be cisgender, and by that we mean assigned female at birth and identify as female. And the reason for that is that we suspected, and it's probably true, that transgender women who've experienced breast cancer and transgender men who've experienced breast cancer might have completely different experiences than those of cisgender people. So we wanted to make sure that we didn't try to conflate those experiences by including a small number of transgender people in the study. And people had to have either a history of breast cancer or a recent abnormal mammogram. The interviews lasted between an hour and 90 minutes, and participants were compensated $50 for participating. And it really focused on their experiences of healthcare during and after their diagnosis with breast cancer or after the abnormal mammogram. The transcripts from those interviews were transcribed verbatim and were coded by 2 different coders, and then they were analyzed using a constant comparison technique. And memos were kept to document the analytic process and also to develop themes. The participants ranged in age from 38 to 64, with the average age being 50 years old. You can see most of the participants identified as lesbian. We had a very educated participant with 50% having a college degree or higher. Most were employed, about half were single and half married or partnered. And the majority had a breast cancer diagnosis, with only a few people having had an abnormal mammogram only. The results have been published recently in the journal Cancer. And you can see that we were very excited about pulling forward one of the titles that stood out for us as a salient quote. "This is a mess," right here. And if you want to read in more detail about the study, you can read that journal article. I'm just going to cover really the highlights in this talk. We use a framework called the self-determination theory to analyze the data. And the Self-determination theory is a framework for understanding what motivates people to do or not do certain behaviors. And there's three constructs: autonomy, which is the feeling that you are the origin of your own behavior; competence, which is the belief that you can achieve a particular outcome; and relatedness is the feeling of being connected with others. And when these three constructs are present and supported by the healthcare environment, individuals are more motivated to do certain behaviors, such as breast cancer screening and breast cancer follow-up care. So I'll talk through each of those themes and share some salient quotes related to those themes next. So around the theme of autonomy, there were both positive and negative findings. For the people who had positive experiences related to autonomy, they talked about feeling like they were listened to and that their choices regarding breast cancer care and treatment were respected. Negative experiences included providers who failed to explain the treatment options or offer other important information, and failed to take the participants' views or opinions seriously. An example of a positive interaction related to autonomy is depicted here, and I'll read it aloud for you. I did what the doctors for the most part wanted in terms of the surgery, doing the tamoxifen and all of that. I knew that was ultimately my decision, but I went with their recommendations. The tamoxifen, like this 10-year thing, I'm not crazy about it. I'm doing it because it's recommended. I know I could stop if I wanted to just because it's my choice. But I still feel like it's primarily my decision to keep taking this, even though I'm not crazy about it. Overall, it's my decision. So you can see that person was not crazy about the treatment, but felt like the choice was in her hands, that she had autonomy in that decision. And this is a negative interaction related to autonomy. And this participant said, this is my third bout with breast cancer, and the first and second time chemotherapy did not give me a good chance. It was like, I was really sick, I almost died. Here I sit before you a third time. So this time I'm going to choose for myself. I will do radiation, but I will not do chemotherapy. I think the healthcare provider should accept whatever treatment options you choose. And I think that Black women, especially Black women, because they think we're dumb already, you know, that we don't know. And so if you go in there like you do know, they don't have a choice but to respect it. So even though this participant talked about asserting her autonomy, it was in response to negative interactions with healthcare providers. For the theme of competence, positive interactions included asking for and finding the types of care that fit their needs, and negative examples were feeling lost or unable to find the information that they needed. And also healthcare systems and providers who failed to provide them with help. So a quote that describes a positive interaction related to competence is, my mom had to take her chemo treatments in the hospital and doctors would come in and they had a great bedside manner. They didn't want to tell you anything. With my mom, we didn't have options. We took what they gave us. I think that prepared me for when I did have to fight that on my own journey. I built my team of cancer doctors. I vetted people, and I knew if I didn't like someone or one of the doctors recommended someone and I didn't find good reviews on them or I didn't feel comfortable with them, then I turned them down. So she felt capable of building her own team. A negative interaction is here. So I'm just laying there and I'm really scared. And so he gives me an order to go see another doctor. I don't have another doctor. So he's like, just call this doctor for follow-up. And I'm like, I don't know where this doctor is. I don't know where I'm going. So her confidence was really undermined by not being provided the information that she needed to move forward with her treatment and her care. And the final theme, relatedness, is a positive one, and it describes positive interactions with healthcare providers who shared at least one characteristic. And you can see a quote here. This participant said, it just so happens that the majority of my doctors are minority women. My radiologist, my breast specialist, my oncologist, my primary care are all women. They're all minorities and they treated me fairly. They asked about my partner. I mean, sexual orientation was just like, that was another piece of information about me that they knew. It didn't make a difference one way or the other. So she felt connected to these providers because they shared a racial and gender with her. Alienation, people described environments that really eroded their autonomy, their confidence, or their relatedness. And the participants described a lack of support. And one example of that is a participant who said, I remember seeing this doctor once. And that was just not a nice guy. I got his name from an LGBT organization. He was supposedly an ally, but he just had a horrible bedside manner. He was very rough, didn't talk to me, tell me what was about to happen. I remember leaving his office that day feeling violated, so I never went back. But I did find another doctor because it was still important. So that experience was so negative that she never returned to that doctor. Another example of alienation is a person who said, I used to ask T to go with me. I'm not sure, so I'm sure they knew I was a lesbian. I even asked for a support group for T, and T was this participant's partner. And she was told, we don't have that. We have support groups for husbands, but she's not a husband. We don't have that. So really not being provided the kinds of support that she needed. So overall, to support autonomy, competence, and relatedness, to improve interactions, positive aspects could be respecting the participants' choices regarding breast cancer care and treatment, finding the type of care that fits their needs, and healthcare providers who shared at least one characteristic. People also talked about on the negative side, having providers who failed to take their views or opinions seriously, systems and providers who failed to help, and having a lack of support. So based on these findings related to the self-determination theory, we came up with a series of recommendations for healthcare providers. The first is diversify the workforce across the breast cancer care continuum so that there are opportunities for relatedness for Black sexual minority women seeking care. The second is to provide training in and model shared decision-making across the breast cancer care continuum to increase autonomy. And the third is to redesign healthcare environments and resources, including support groups, to be inclusive of people from diverse backgrounds. Next, I'll talk about phase 2, the quantitative phase of the study. This included a 30-minute survey that was web-based online. To be eligible, participants had to be assigned female at birth and identify as female, be 35 years of age or older, and have a breast cancer diagnosis within the prior 10 years or an abnormal screening exam within the prior 2 years. And they were compensated with a $25 gift card for participating. And our goal for this was to really enroll at least 100 of the 4 groups that you see listed here. We wanted at least 100 Black sexual minority women, 100 white sexual minority women, 100 white heterosexual women, and 100 Black heterosexual women. And it was important for us to understand how we were able to reach different types of participants for this study that enrolled such a diverse group of people. Overall, over 2,000 people completed the eligibility screener, and over 1,000 were eligible, and a little over 800 completed the survey. The participants ranged from all across the United States, including 46 of the 50 states. Most were from California and Georgia and New York. The average age of the participant was 55 years old. And in terms of the identities that we wanted to make sure we included, 37% of the participants were Black women of any sexual orientation. If we looked at any race, 31% identified as sexual minority women. And if we looked at Black sexual minority women overall, about 12% of participants were Black sexual minority women. Then we wanted to look at what were our most productive ways of reaching different groups of people. So we asked participants in the survey how they found out about the survey. In terms of reaching sexual minority women, 32% of the sexual minority women that we reached were through the Love Research Army. And I know earlier it was mentioned that 6 people participated. So those 6 people who reached out about the study were for the qualitative phase, and many more people from the Love Research Army reached out about the quantitative phase. 21% of the participants reported learning about the study from Facebook, and unfortunately we weren't able to tell if it was our study Facebook page or the Zami-Nobla Facebook page. We suspect some of these women found out through the Zami-Nobla Facebook page. And then Zami-Nobla, not surprisingly, was the most productive partner in terms of reaching Black sexual minority women, with 40% of the Black sexual minority women participants saying that they learned about the study from Zami-Nobla. And looking at the data, we had a couple of research questions that we've asked so far of this quantitative data. The first being, to what extent are Black sexual minority women likely to experience delays in breast cancer care? We know that this is an issue among Black women in general. How does this look when we look at people by race and sexual orientation? You can see here, I'll orient you a little bit to this slide with a lot of data on it. On the left-hand side, you'll see a the left-hand column, you'll see a series of outcomes, and along the top, you'll see the different groups. So white heterosexual women is HSW, white sexual minority women, Black heterosexual women, and Black sexual minority women. And you'll see the number of participants in each group after that title. So when we look at the proportion of participants in each group who delayed seeking care after a breast cancer diagnosis or after an abnormal screening for more than 3 months, we see some significant differences, right? So among Black sexual minority women, almost a third had delayed care for at least 3 months. And that's almost 3 times what we see in white sexual minority women and Black heterosexual women. And you can see only 5% of white heterosexual women had delayed care for that long. We also see differences in terms of demographics. So the Black sexual minority women were younger, which is what we see in the literature around breast cancer diagnosis in general. We see a highly educated group. 85% of the Black sexual minority women had a college education, 75% of the Black heterosexual women, and so on. And we see dramatic differences in income. For the Black women, whether they were heterosexual or sexual minority, you can see a little over half had an income greater than $50,000, compared with 80 to 90% for the white women. And finally, if we look at some psychosocial factors that we also measured, we looked at social support and experiences of stigma. And you'll see that the scores for experiencing high levels of social support were greater for white women than they were for Black women. And if you look at sexual minority women, Black sexual minority women had the lowest social support score. And if we look at experiences of stigma, you can see that the highest scores for stigma are among Black sexual minority women and the lowest are among white heterosexual women. Then we modeled all of these things together. In the first model, we included the 4 groups based on sexual orientation and race, and you can see that we, in that first column under model 1, if you look at odds ratio, which is that first column number, that if you compared these groups to white heterosexual women, Black heterosexual women were over 2 times as likely to have delayed care, and Black sexual minority women were more than 7 times as likely. But we want to take into consideration other factors that we know are related to delaying care, like income, experiences of stigma, and social support. So if we look over at the second model, it includes income and experiences of stigma. I'm sorry, income was also included in the first one. It includes experiences of stigma, and you can see that still Black sexual minority women had a higher odds of experiencing a care delay. And if we include social support, that relationship still remains significant. So even if we take into consideration these other factors that are related to delaying care, Black sexual minority women are more likely to experience care delays. And it's really important to us that we understand that as not being related to something intrinsic to race or intrinsic to their sexual orientation, but likely intrinsic to their experiences as Black sexual minority women, which were outlined in the qualitative data. Our second research question was, what were the barriers and facilitators that were associated with appropriate breast cancer screening and follow-up care after screening? And we asked people to describe to check from a list of options their reasons for delaying care. And we grouped those into structural reasons, which included cost, transport and childcare, institutional reasons, which included things like inability to reach their healthcare provider to schedule an appointment, interpersonal reasons like fear of being stigmatized or experiences of distrust, interpersonal reasons like feeling it was pointless, feeling embarrassed about their diagnosis, and not wanting to worry other people, and minimization, meaning having other priorities, not experiencing any pain or not believing the test results. You can see there was some diversity across these different groups, with pretty much all of the groups experiencing some level of structural barriers. But if you look at institutional barriers, you can see that that's higher among Black sexual minority women. If you look at interpersonal barriers, you can see that that's the highest among Black sexual minority women, as well as minimization. So our conclusions overall, looking at all of the data together, is that community engagement is essential for reaching breast cancer survivors who are multiply marginalized, like Black sexual minority women. Promoting autonomy, competence, and relatedness can increase Black sexual minority women's engagement with the breast cancer continuum, and increasing social support, decreasing stigma, and reducing structural barriers may reduce delays in accessing care. And again, I'd like to thank our research team that you see pictured here: Marianne Adams, Naomi Green, Joanna Malone, Christy Treadway, and Sophia Geffen. And I think with that, I will stop sharing my screen and I will turn it over to Dr. Dean. Thank you.
Thanks so much, Tonia. I hope everyone enjoyed the presentation so far. I want to elevate that this entire concept really speaks to Dr. Poteat's brilliance. She came up with this idea and was gracious enough to include me in it. My work is in social determinants of breast cancer, and Tonia's work is primarily in outcomes for sexual and gender minorities. So thank you to Tonia, first and foremost, for allowing me into this project. And we're excited about the results and where we can take this next, which is to consider interventions and types of things that can better serve sexual minority women in the course of breast cancer care. We'd also like to thank Army of Women. One of the things that was amazing, I should say, Love Research Army. Thank the Love Research Army. As Dr. Poteat mentioned, was a very strong partner in recruitment. And in fact, I think in one day, we actually had several hundred people sign up for the survey. I mean, it was amazing how it accelerated the success of this project. So thank you for your partnership. So I guess we can just open it up. Are there any questions from the audience or the moderators that we can help answer about the study?
Well, I actually had a question on something you just touched upon, and that is next steps and interventions and things like that. So are there any plans right now for taking this data and moving forward with some interventions, testing interventions?
So the plan from the beginning, we really had in mind the thought of turning this into an intervention, and we saw that is happening in 2 steps. One, we'd actually like to create some sort of, we'll call it a risk model or some sort of profile that can help providers identify very early, based on characteristics, who is most likely to delay. What are those characteristics? What can we look at to try to say, this person is most likely to delay? We need to make sure we're really following up with them to make sure they have what they need to get care or engaged in care. But the other component to that is thinking about actually training healthcare providers. And healthcare providers could be many people in that system. So if for those who have gone through breast cancer care, right, there's the person who does the mammogram, right? There's a radiologist, there's an oncologist, there's the surgeon. There are many people that nurse practitioners, physician's assistants. I mean, there are just many people involved in that care continuum. So what we'd like to do with these results next is to start thinking about who are those providers that we need to target around those areas of autonomy, incompetence, and relatedness. How do we use our theoretical framework to help define who we should reach out to and how best to train them so that they're best able to serve sexual minority women in particular, but really, honestly, any woman who walks in the door and is at risk for a delay in care.
And I guess, what do you think the impact is of COVID? Because I think a lot of things are being impacted right now with timelines. So how is that impacting the work?
So right now it hasn't impacted our work specifically,
Great.
but in general breast cancer care, people have seen reductions in screening. Interestingly, I haven't seen any studies yet that have looked at delays in follow-up after abnormal screening during COVID, but there is some evidence from particular cancer centers and from a couple of states that suggest there have been delays in the initial screening. But in terms of the work that we'd like to do and we'd like to propose, right now, we're not seeing any challenges. We should still be able to reach out to healthcare providers and others because people are still engaged in breast cancer care regardless of COVID.
Yeah, I definitely agree with that. Well, is there anything else that the two of you would like to discuss in relation to the project or next steps or anything?
Well, I don't get to talk to Dr. Dean very often, so I'm you know, as you mentioned, we brought different areas of expertise to this project, which I think is one of the things that made it so fantastic. I learned so much about breast cancer. Were there any of the findings that surprised you, given your long experience doing this kind of research?
In terms of the delays, in terms of the breast cancer components, no, not so much. But in terms of some of the other results you showed, yes. So we talked a lot about one of the things that we were surprised at is that the levels of reported discrimination were as high among white sexual minority women as they were among Black sexual minority women, right? We originally conceptualized this project to think about multiple marginalizations, right? So being a woman, being Black, and being sexual minority. And I guess we thought we would see more of a dose-response relationship with Black sexual minority women being far and above in terms of their experiences of discrimination. But I was really surprised that white sexual minority women are also feeling this sense of discrimination when it comes to breast cancer care. I don't actually think that I haven't really seen that documented anywhere else. So I think that'll be interesting for us to think about as we carry this forward and how we need to equip healthcare providers, especially since one of the things we have been talking about is that, you know, a healthcare provider will easily recognize that someone is a Black woman in many cases when you walk into the door, but you might not recognize that the person is a sexual minority. There would be really no way to know that when someone walks in the door. So might not recognize that they need to really be embracing and adjust their behavior. So I think that's something for us to think about is what happens when the quote unquote marginalization might not be as visible, and how do we train healthcare providers in those contexts to best care for patients. How about you, Dr. Poteat? Surprises?
I agree with you. I didn't have a ton of surprises. I think there was one slide that I won't go back to, but where I think it was maybe the education slide where Black heterosexual women actually had lower levels of education, and Black heterosexual men had, I think, another experience that was actually more marginalized. And I was surprised by that and curious to know more. I think there's so much more we can dig into around the data. I'm curious about regional differences since we had such a wide range of places people were from, if that might explain some of what we saw. But most of it, I think, was what I expected to see, but maybe not to that degree. I think a 5-fold increase in delay in care, even after controlling for things like stigma and social support, was really
shocking
more
and
depressing than, yeah.
Yes, shocking and disappointing. Yeah, we need to do better. We really do.
Was there anything that you were expecting to see that you didn't see?
I know we're both like, huh.
Well, I think some of the research that we've been doing at the foundation, with some collateral damage research we've been directly asking, you know, cancer patients for their feedback on the type of collateral damage they're experiencing to know what to look at and what to research further. And I think that in that aspect, asking the patients those questions, we saw things that were things we hadn't really thought about. So kind of getting that feedback from the patients on things maybe that the researchers themselves aren't thinking about. But if not, maybe if you, like you said, it sounds like you more saw things, there were things present that you weren't expecting versus things that you were expecting to see but weren't there.
Well, I would say most of my surprises came from the qualitative data, and I think that makes sense, right? We only know what we asked in the quantitative data, but with the qualitative data, we could really hear people's stories. And I know I was having a conversation with Marianne Adams from Zami Nobla about how we were still very surprised by how much stigma there is still associated with breast cancer, and that some of our challenges related to recruitment, which we didn't talk about a lot, but we can, were related to people feeling a lot of stigma, a lot of secrecy, and a lot of shame around a breast cancer diagnosis. So that was definitely a surprise and something I hadn't really considered.
So that's a good point, the findings about stigma, Dr. Poteat. So I come from a family where, I mean, literally the word cancer is still whispered. I mean, people don't even say it out loud, they whisper it, right? There's a fear there even before someone has it. And so part of my message to my family is there's so much life to live after a cancer diagnosis. You don't have to be afraid of it. So one of the things that did surprise me, and I was thinking about the slide that you had about the various reasons for delaying care, is that I believe that Black heterosexual women did not have as great fear of stigma. I don't know if you want to put that slide back up. But the reasons for delaying care, because that's something I expected to see just from my own family members' experience anecdotally, but then didn't see it in this study.
Can you see my screen now?
Mm-hmm.
Okay, so this is the one?
Yes. So for this slide, you know, there was the structural, institutional. If you look at interpersonal included feelings of distrust and then fear of stigma. You could see the blue bar represents white heterosexual women, and then the orange bar is white sexual minority women. But then there is nothing where the Black heterosexual women, there would otherwise be a gray bar there, but there's actually none. And then Black sexual minority women, you see that yellow bar going up. So I think the absence of the gray bar there was something that really surprised me just based on my own personal experiences.
Okay, well, we do have a question from Dr. Susan Love, who's joining us as well. And she is wanting to know, what do you think the role of nurse navigators could be?
I see Lori thinking, so I will
Yes.
take a stab at the thought. I think navigators are incredibly helpful, especially, you know, we've just recently submitted the quantitative paper, and so I was digging into the literature around social support and how important that is. And we see that also in our own data. And I think what we learned from this study is that who the nurse navigator is really matters, and having the ability to relate to the person who is seeking care is really important. And some of the ways to do that is by having a diverse workforce. But I think there are also other ways with the workforce that we have now that we can increase relatedness. And what your thoughts are, Lori?
I would agree. I was trying to, what I was thinking about is I was trying to remember if we, any specific results about nurse navigators. And I don't remember them specifically about nurse navigators. But I do think that's a great question, because it reminds us again, right, there are all these different points of care, and there are multiple people who, as we think about an intervention, right, need to be trained. We need to be thinking about multiple levels. Because everyone plays a different role. So, yeah.
Yeah, and I was thinking about particularly the quote from the person who had, there was no support for her partner, and a nurse navigator who had access to resources and knew a place where that person could get support would be, I think, really important for people who feel marginalized outside of sort of the mainstream healthcare system.
And Dr. Poteat, you had mentioned briefly something about recruitment. And so was it a struggle to recruit for this study?
Do you want to take that, Lori, or me?
You can go, you can start.
Okay, yes. So well, full disclosure, our original plan for the qualitative work was that we would recruit 30 people. And we didn't think it would be a problem, mostly because one of the impetuses for the study is that I sat down one day and I made a list of all the friends I knew who had breast cancer, and it covered the front and back of one page. And I'm 50 years old. So I was like, okay, that will not be a problem finding people. But again, the shame, the secrecy, the stigma was really a challenge. And so we stopped at 15. And then for the quantitative data, we were committed to getting 100 Black sexual minority women. And as Dr. Dean mentioned, when we first opened the study online, we had a ton of other people complete the study, which was great. So we met our recruitment targets for all those other groups fairly quickly. And so we had a decision to make. Do we continue or do we stop with a smaller number? And we didn't want to be like all the other studies we had read that had like 5 or 6 Black sexual minority women and not enough people to really make any conclusions. So we closed the study to other participants and continued to enroll until we reached our target.
Okay, thank you. All right, we have another question from the audience. Is there a reason why you did not use any male breast cancer people in this study?
Male breast cancer patients are clearly an important population. In our case, we had a couple of reasons why male breast cancer patients weren't involved, but the main reason would be that we were thinking about people who would be engaged in routine screening and then experience delays. And as far as I know, right, there aren't any recommendations for males to be routinely screened and then experience a delay. So in terms of the scope of the study and who we were looking for, it would have fallen outside of the scope. But again, it's that same question as we thought about, well, what about gender minorities? What about trans men and women, right? We also feel like those are certain populations who will have additional considerations and really are warranting their own study. So I think actually this is a good call to action to think about. It would be really neat to replicate this or somehow reformulate this in a way that would be appropriate for males with breast cancer who really do need and deserve more attention.
And we did have one of those, at least I had one of those post-study moments where like, why didn't we ask this about gender presentation as well, that the experiences of sexual minority women who have a more masculine gender presentation versus a more feminine presentation might be incredibly different in their engagement with the healthcare system. And we didn't ask that question.
Well,
so more to do.
Other follow-up studies. So. Great. Okay, well, I think we've gotten through the open questions. Is there anything else that you'd like to touch upon about the study or future directions? All righty. Well,
I would say thank you again. Yeah, thank you again for your partnership. I mean, we really would not have had these robust results without Army of Love Research Army. I'm stuck in the past. Love Research Army's collaboration. So thank you for the work that you're doing. Thank you for the ways that you're serving. And thank you for making yourself a resource to researchers like us.
Well, we are very happy to be working with teams like yours, very excited to help move research forward like this. And I know that the Love Research Army members are very, very dedicated and motivated and excited to participate in studies like this. So when you're ready for the next one, you let us know and we'll be happy to support you again. But we want to thank you again, both of you, Dr. Poteat and Dr. Dean, for your time today and for participating in this webinar and partnering with the Love Research Army for the study. Like you said, we are very excited to be working with research teams all over the country and throughout the world. And the research members, the members of the Love Research Army are excited to see new studies come through. So thank you for that. If anybody does have any questions that is joining us today and that were not answered, or you would like to get in touch with the foundation about the Love Research Army or any of our research initiatives, you can email us at info@drsusanloveresearch.org. Today's webinar has been recorded and will be posted soon to our website, which is linked in the chat box for your convenience. And I want to encourage our viewers to visit our website if you're interested in learning more about the foundation or making a donation in support of our mission to end breast cancer. Your donation is a direct investment in our research initiatives, including the Love Research Army. So I thank you in advance for your consideration. And I want to thank everyone for joining us today, and I hope all of you are staying safe and healthy. Thank you so much.
Thank you.